I just
All
approved
right.
it.
Success.
Thank you.
All right.
Sorry.
All right, with that we can go ahead and get started.
Well, good afternoon. Thank everyone for joining us. We are here for the August 14th meeting of the HERC. So here's our call to order. So why don't we start with a roll call? Daphne, are you helping with that today? Okay.
Absolutely. Thank you so much, Adrian. Mark Buckholz.
We can't hear you, Mark. We saw the thumbs up.
Okay.
How about that one,
Stacey Geisler.
present?
Excellent. Oh, and I'm seeing Katie joining us. Katie, I'm promoting you right now. If I can find it.
I just did, Daphne.
Thank you so much. Okay,
Thank you.
so we've got Mark, we've got Stacey Geisler,
Present.
Lisa Kouzes,
Present.
Larry Lyon,
I am here.
Chris Pinzon,
Here.
Katie Schable.
I'm here. Thank you.
Excellent. Thank you, Katie. Leslie Sutton
Here.
and Adrian Irwin. Did I get everyone?
Yes.
Yeah, we have 8.
Awesome.
That's great.
We have 8. That's wonderful. Thank you, everyone.
Perfect. Thank you so much, Daphne. Jason, did you want to do the orientation presentation?
Let's go ahead and do that. So while she's bringing that up, just to remind everybody, especially those attending from the public, this is the Health Evidence Review Commission, and the purpose here is to make coverage decisions related to services on the Oregon Health Plan. These decisions will affect over 1 million OHP members, as well as people's family caregivers and healthcare providers. There will be no decisions about anybody's individual care. We can't discuss that in a public setting, but we are making policy decisions here. And all of this in the context of the goal of the Oregon Health Authority to eliminate health inequities by 2030. So we're doing our best within our scope of authority to contribute to that. We'll also be hearing public comment. We have somebody here in person to offer public comment a little later. Decisions are not final, if you've seen the meeting materials, unless approved by this body, and they will be implemented at later dates. Mostly today, the decisions will be implemented on October 1st. There are some exceptions to that, especially with regard to the benefit update project. Anything that says benefit update project will be implemented in 2027, if all goes according to plan. The general considerations here include the assessment of the balance of benefits and harms of each service for the population. We also consider patient values and preferences, what's important to patients. We consider stewardship of public resources and the nature of our Oregon healthcare delivery system. Next slide. And so if you attend online, members, if you can stay on camera and attentive, if you need to step away or go off camera, please message Daphne so she can keep track of that. The votes will be by roll call. As required by public meeting law, Daphne will be calling the roll today. And we ask that you speak up or raise your hand rather than using the chat, just so we can have everything in the public discussion. If you're just attending as a guest, the chat is disabled, but you can use the Q&A feature and we'll answer to the best of our ability. The chat and Q&A are part of the public record, and the meeting is recorded and will be posted online. So remember that as you decide what to share. If you have other feedback we can address during the meeting, you can always reach us at herc.info@oha.oregon.gov. That's our email address that all of our staff read. We'll route it to the right person, and we can usually respond within a few days. With that, we can move on.
Perfect. Now, the next item for housekeeping is just an opportunity for anyone to declare a conflict of interest as relates to any of the items on the agenda. Are there any conflicts of interest for members to disclose? Okay. Okay, so continuing down the agenda, the first, so I will, I think, clarify with minutes. So as a kind of friendly reminder, at our June meeting, the minutes from the May meeting were not ready to be voted upon. So we actually have potentially 2 sets of minutes to approve. So the,
Actually, we got more than that. We
Oh.
discovered a couple of other things. So in addition, so the May and June HERC minutes. And then there was a correction this morning made to the VPBS minutes. Yeah, could you bring that up to the June EVGS minutes? And then in addition to what Liz will bring up now, the April EVGS minutes were not ready for the June meeting. We just had a lot going on this spring with the BOP
Right.
project. And so we'll actually need to approve, and with no corrections, as far as I know, the May and June HERC minutes, in addition to the corrected June VPBS minutes and the June, sorry, April April EVGS minutes.
And I think
So-
that all starts on page 8, I think.
And then Nate was added later.
Yeah, and the May HERC minutes were sent out to you members by email. If you're comfortable voting on that, we can approve those today. Otherwise, we can bring them back in October. We can also vote on them and amend them if needed, if there's anything we missed today.
thank you, Jason.
Thank you for your patience with us. We will do our best to stay more on top of these. But the revisions to the minutes are just around some comments Dr. Cruz has made at the VBS. And you see the edits, just a little more accurately tracking what she said in the meeting there. So with your permission, we'd like to make those corrections.
I'm sorry, should we be looking at? What should we be looking at right now?
So the only minutes that are different than what we sent you or put in the packet are the ones on the Zoom, shared on the Zoom screen. Oh, can you move back to
And
those,
it's-
Liz?
Yeah. So Dr. Lyon, Liz will put up the track change version. So the question or I think the comment on the floor is the minutes as listed on the screen, not in the packet.
Okay, so I'm actually going to the HERC website and looking at the materials there.
Yeah, and those do not include those edits to Dr. Cruz's comments, but otherwise they're right.
Okay, and the only adjustment is what is on the screen on the
Correct.
Zoom now.
Correct.
Okay,
And I'll just add that we looked at a transcript of my testimony too. So what is up there is suggested for changes is verified.
okay.
Any other questions from the commission? I'm gonna take these as like 4 different votes, because I think there's a couple of different moving pieces.
Okay.
With no other questions, do I have a motion to approve these minutes? The VBBS minutes as corrected on the screen is the motion that I'm looking for.
I move to approve. Second.
I have a second from Lisa in the room. Daphne, do you want to do the roll call?
I do. Mark,
I approve.
Stacy,
Approve.
Lisa,
Approve.
Larry,
I'm sorry, I'm still looking. Okay. So the adjustment is on the Zoom call. The minutes this is for the June VBBS meeting, is that correct?
Correct.
And that is on the HERC website, is that correct?
No, this is being corrected and we will post it on the HERC website.
Oh, is this just a motion to approve the adjustment?
Yes.
Yes,
Correct.
and
Oh.
the full minutes.
And the full minutes incorporating that change.
Okay,
Yes.
I don't see the full minutes. Sorry, I don't mean to hold things up, but where is that?
The June VBBS minutes.
Okay, all right, so on the website, it says past meetings, VBBS subcommittee meeting. Is that where the minutes are?
It's in the meeting materials.
It's in your meeting, it should be, this one should be in your meeting materials today.
So this is page 17 of the packet for today. So if
Okay,
you go to page 17 of the
wait,
packet,
okay, just a minute. Where is the packet? I'm sorry, I'm a little lost here.
It is on our website for today.
Hey, Larry, just let me put that in the chat for you.
Interesting.
Uh, hmm. Okay, I'm looking at the materials on the website. Okay, that's for
It's a combined packet between VBBS and HERC.
okay, so I'm looking at the materials for today.
Mhm,
Is that correct?
that's correct.
Okay, and then what page do the minutes start on?
Page 16 begins the VBBS summary,
Okay,
and then
All right.
the meat of the VBS minutes
Minutes.
are on page 17.
okay, very good. Can you poll the other members first while I take a quick look through this?
I can. Thank you.
Okay, that'd be great. Thank you.
Thank you very much. Chris Pinzon,
Yes, I approve.
thank you. Katie,
Approve.
Leslie,
Approve.
and Adrian Irwin.
I'll let Dr. Lyon go first since I'm chairing.
Okay. Yeah, right. Sorry.
No worries.
Up in the air.
You could abstain. And Dr. Lyon, if you're not comfortable voting, you could abstain.
I'll just abstain for now because I have not finished reading through them.
Okay.
And then I'll approve Daphne. So I think we
Thank
have enough
you.
for to move
Motion
forward.
passes. Thank you.
Great, thank you. So from there, I'll stay. I'm gonna do it.
Okay.
That's okay. So I'm going to go to the HERC minutes that were included in your packet. So if you are in the packet, Daphne, what page is that? Page 8?
Page 8. Thank you.
So these are the minutes from the June meeting. I'll take a motion to approve, or I guess any questions or corrections? Hearing none, do I have a motion to approve?
So moved.
This is Leslie. I'll move.
Okay, I'll second.
Okay. Mark,
I approve.
thank you. Stacy,
Approve.
Lisa,
Approve.
Larry,
Just come back to me.
excellent. Chris,
Oops. Approve.
Katie,
I'm gonna abstain because I wasn't at that meeting.
thank you so much. Leslie,
Approve.
and Larry, are you going to abstain?
No, I'm going to, the last page of the minutes is page, there it is. Looks like page, yeah. 15 of the packet. Yes, I approve.
Thank you. And Adrian,
I'll approve as well.
motion passes. Thank you.
Now, in addition to that, so then I'm going to back up a moment. So the minutes for the May meeting of the HERC were not included in your packet. They are now available online and they were sent on email this afternoon at about 12:03. So these are the minutes from 5:15. So if the group is comfortable, we can go ahead and approve those minutes today. If folks feel like they want additional time to digest, then we can push that to another meeting. So I'm open for comments as to what folks would like to do today.
And why are we approving these now as we didn't approve these in the June meeting?
These weren't ready at the June meeting.
Oh,
We just
got
had
it.
several meetings right in a row and we're not able to complete them.
Um, I'm looking for the May minutes.
So those were sent to you by email at 12:03 PM.
Okay, so I have something from 12:02.
Yeah, that's
And it's
margin of
just,
error. Yeah.
okay, is this here they are, okay.
I've had a chance to read them and I move to approve.
A second. Any further discussion?
So I have a motion and a second. Any further discussion? We could also move this to the end if folks want just a little bit more time with this.
Well, let's go ahead and call the vote and see what people.
Absolutely. Mark,
I approve.
Stacy,
Approve.
Lisa,
Approve.
Chris,
Approve.
Katie,
Approve.
Leslie,
Yes.
Larry.
Just come back to me. I'm just finishing up.
You are the last one before the chair.
Okay.
I did
All
that
right.
for you.
Yeah, okay, thank you.
Dr. Lyon, I'll approve. So if you just want to abstain, that's fine as well.
Okay. I feel rushed looking through these things.
Again, apologies for this one. And if you want to abstain, that's totally fine.
I'll abstain.
Okay.
And then the last set of minutes we have are the balance.
April EBGS minutes.
And are those in the packet?
Those were in the packet.
What page
So-
are we?
54.
50.
So those are page 54 of today's meeting materials, and those were provided last week.
Okay.
Any comments or questions? If none, I will take a motion to approve.
I'll move to
Wait,
approve.
wait, wait. That's
This is Chris. I
June.
moved a second.
Quick question. Why are we approving these minutes?
Again, because they were not ready for the April or the June EBGS meeting. And so,
Well, they just, minutes from the April 10th meeting were reviewed at the EBGS June 12th meeting. 5 members voted to approve, but 6
Oh,
are required
thank
for
you.
action. The minutes will be reviewed again at the next meeting.
yeah, so I'm sorry, that's right. Thanks, Liz, for reminding me. Somebody abstained, and so there weren't enough votes to take official action. Most of the votes, people who did vote, voted in the affirmative. It's just we made an error in calculating quorum. And so we're trying to cure that here.
Got it. Okay, that's why we're approving the EBGS minutes here. Okay,
Correct.
thank you.
Y'all ready for me? Mark,
Oh, I approve.
thank you. Stacy,
Approve.
Lisa,
Approve.
Chris.
Approve. I couldn't find my
Thank you.
button.
Oh, thank you. Katie,
Approve.
Leslie,
Yes.
Larry,
Able to see these because these were in the packet. Okay.
excellent. And Adrian,
Approve.
motion passes. Thank you.
Perfect. Thank you so much for bearing with us through lots of different minutes. So with that, I will turn it over to Jason for the director's report.
All right, relatively short director's report compared to last time. There were several bills affecting our work in the legislature this term. None of them passed. And there were several mandates to kind of reverse decisions that were made here. None of those went forward, I think likely because of the fiscal impact and the tight budgetary situation, perhaps other reasons. The one caveat to that is one of the bills was related to the benefit update project. And although the bill didn't pass, it would have authorized a work group I'm sorry, it would have been called a task force. But OHA is doing sort of a light version of that, without, to the extent that we can, without a legislative appropriation, to ensure alignment on the benefit updates project. Adrian, is our HERC representative on that group. Those meetings are public. They'll be meeting twice a month through the end of the year. Our EBGS member, Kat Livingston, former contractor for the HERC, is also on that, as is Mary Engrad, who's on the DVBS committee. So we have, good people with great understanding of our work at HERC on that. And our staff will be participating as well. We just had the first meeting yesterday. In coverage guidance world, for EBGS, we have just a status update for that. I think in January, you all heard a recommendation from the EBGS to defer work on a coverage guidance on surgeries for sleep apnea. This is different. I'm sorry, not surgeries, hypoglossal nerve stimulation for sleep apnea, which is different from what you heard in June about the surgeries. And that was deferred for a year pending new evidence. Some limited new evidence did appear. It did not change the overall status. But that will be going to our EBGS meeting in September 11th, for those of you on that subcommittee. And so we'll run that through the process, whatever the recommendation may be based on the evidence that was reviewed last time with the additions from the more recent publications. In addition to that, we will be publishing on Monday a scope statement on Omnipods, which is an insulin delivery device that's sold at pharmacies that doesn't have a tube, which apparently is preferred by some patients. And so looking at the evidence and appropriate situations for use of those Omnipods, and that will come to our February EBGS meeting and hopefully to you all for approval of the scope statement either in October or November.
Would it be I have a quick question. Would it be helpful to know what happened in the legislature about what mandates were, what happened, the specific issues?
So there was a bill related to continuous glucose monitors that would have broadened coverage more broadly than you all approved. Again, that did not pass out of the first committee. Help me out, Liz. What was the other one?
Stent in a carotid artery.
Oh, coronary artery calcium scoring.
Yep.
That also did not pass out of the first committee. And I think there was
CGM.
CGM I already mentioned. I think those were the only two. And then there was a bill introduced by the agency related to benefit update project, which didn't move, and another one introduced. I don't recall who introduced that, but it was the agency had some input on that one as well, but that also didn't move, again, likely because of the fiscal situation.
Okay, thank you.
Okay. The other thing is we will be bringing to this group a recommendation on some materials on autism spectrum disorder. I'm sorry, not autism. Scratch that, not autism. Applied behavior analysis, which is often used for autism spectrum disorder, but this was requested, you heard public testimony a few months ago for intellectual disabilities. We've done some work around that. We'll put it out for public comment. We're targeting that for the January meeting just to make sure we get through our benefit update project work. So that is my staff update. Are there any questions or comments about any of that? Okay.
Stacy, we see your hand.
Yeah, Jason, on the political side of things, like the CGM, the continuous glucose monitoring, do you think that's going to be taken up again? It sure would be nice for Oregonians to be able to have access to that.
So are you asking whether it will be taken up in the legislature?
Yeah, or what's going to happen to these things that were killed?
Yeah, I can't say. It depends who introduces a bill. Each representative or senator can introduce a certain number of bills and they make the decisions about that. We, of course, will be looking at it again if there is new evidence that might change the conclusions, or on a 5-year cadence, because I'm sure it will be continue to be an interesting topic for members.
I'm seeing a lot more patients with CGMs.
Yeah, and then, we're gonna be in this world again for the insulin delivered
Yeah.
device, which is related.
Well, seeing no other questions, we want to transition to the BBBS subcommittee report.
What page is that on?
Or the BB,
I'm sorry.
We're getting
we're
there.
getting there.
Oh, okay.
Okay, so page 72 of your meeting materials for today has the straightforward agenda.
Agenda. Let me just finish putting this.
So I think I caught Ariel mid-thought.
So BPS met this morning and we had a pretty full agenda. We had our usual straightforward issues. There was no discussion there. They were all approved as were in your meeting materials. We went on to our previous discussion items. We're continuing to talk about cervical spine manipulation for cervicogenic.
Wait a minute, did we do the ICD-10 codes? Or those?
Oh, I skipped ICD-10 codes completely. Thank you. We looked at the placement for the 2026 ICD-10 codes. They were mostly straightforward, meaning they followed previous codes, or they were very similar to previous codes. And then there were a few pulled
Dr.
out.
Lyons, page 71 or
Thank you.
72.
There were a few pulled out for discussion because they
No, I'm sorry.
generally.
Correction, it's page 77. for the
Thank you.
codes.
Okay, yep.
The ones that I had flagged for discussion simply didn't either go with their code family or needed a little bit of clarification. There was no discussion of any of those. They were all approved as in your meeting materials. Just as a note in your meeting materials, there are 2 placement recommendations. There's one for 10/1/25. And then there is a second placement recommendation for 1/1/27 for some of the codes, and that's simply because of the BUP process, we've already changed lines or code groups, et cetera. So there are 2 placements for some of these codes.
I'm sorry, I don't understand what do you mean by placement? I don't understand.
So there's a list of new diagnosis codes and they need to be put onto a line on the prioritized list or in a file like the diagnostic file. So the placements were all outlined in your meeting material. They would list either a line or another file. And then for the 2027 list, they would, or 2027 BUP, it would be a code grouping that would have been listed.
So it just means assigning what to do with those codes and how they should be treated in claims adjudication.
Okay, thank you.
Any other questions about ICD-10 codes? Anyone want me to pull a code out for more detailed discussion or explanation? All right, moving on then. For previous discussion items, we were talking about cervicogenic headache and cervical spine manipulation, either osteopathic or chiropractic.
Page 125.
Thank
We
you.
talked about this at several recent meetings. At the last meeting, we discussed that staff were directed to look at the literature of effectiveness to see how many treatment sessions were used in the studies that showed effectiveness. I conducted that, and it was somewhere between 6 and 18 visits. Most studies were reporting either 6 or 12 is the appropriate number. The group this morning thought that 12 was a good number compared when you looked at the underlying evidence and how many treatments were needed for effective treatment. There were a couple of staff options. The group unanimously this morning wanted the option where cervicogenic headache will be placed into the code grouping for the medical treatment of back conditions, which already has the CPT codes for chiropractic and osteopathic manipulation. And there will be additional wording. There were some modifications for what was in your packet. So we would place the ICD-10 code for cervicogenic headache into the medical back code grouping. And then the guideline that would go with that had mostly the technical changes that we're doing for the BUP change. Then there would be a couple of additional changes. Under the 30 visit sort of global limit that we have for acupuncture, PT, OT, and chiropractic osteopathic manipulation, the group this morning wanted to flip acupuncture and chiropractic, so the chiropractic line was closer to the cervicogenic headache line. There's additional wording that the chiropractic visits include those used for cervicogenic headache. And then there's wording placed in there that cervicogenic headache is just in this code grouping for pairing with the spinal manipulation codes, and that they are limited to 12 visits per year, and those 12 visits are included in that overall 30 above. The wording that you see highlighted there is the wording that was changed. And then as well, flipping acupuncture and chiropractic and osteopathic manipulation is a change from current guideline note.
To be visually closer.
To be visually closer.
Yeah.
It doesn't change the
Yeah.
impact of the coverage. Questions?
Now,
Larry, did you have a question?
yes, what page are we on now?
120.
So this is on a 130 in your packet, I believe.
Okay.
But then there were changes that were made, what is in the packet as compared to where BBBS landed this morning. And the two changes are that they switched 2 and 3, and then the text highlighted in yellow.
That is showing on your screen.
I have a question. From up above, I think it was page 122. Was there something about where, but making the cervicogenic headache part of back pain? I'm sorry, what page was that on?
Yeah, so that was the option that BBBS unanimously voted to approve. It would take cervicogenic headache, which is a headache caused by neck issues. It would put it into the code grouping that would include all of the other back and neck,
spine.
yeah, back and spine type of conditions. And which would then automatically pair with the chiropractic and osteopathic manipulation. We wouldn't need to add those to the headache line.
So does that effectively increase coverage or just change where it is in the BUP? Or both?
It solves an issue where we were proposing putting cervical spine manipulation into the headache line and having to add those codes and have a guideline and that kind of thing. It simplifies that a little bit, but also especially the particular wording that was changed this morning clarifies how many visits.
Okay.
So someone with cervicogenic headache can have 12 visits of chiropractic or osteopathic care specifically for the headache, but that counts into the 30 that we allow for all back and spine conditions.
Okay. Thank you.
And it will add coverage with the BUP because currently it's a non-covered
Right.
line.
Yeah, it's additional coverage, but no more treatment visits.
Yeah, and you could have been getting manipulation of your cervical spine for neck
Okay.
pain.
Yeah.
And so it's making a more appropriate diagnostic pairing.
Okay.
I feel that
This
works
is-
for, if anyone wants to. No
This
comment.
is Daphne. Hi, this is Daphne. I'd like to welcome Ben Hoffman to the meeting.
Welcome.
Welcome, Ben.
So I don't know if people heard Lisa Kuz's, she had reviewed the changes that were proposed and her expert opinion, they're agreeable.
Yeah, I'm agreeable with that way of, setting a limit on the visits and stuff. Yeah.
And then I'll just further add, so if you're looking at the meeting materials, it does provide two options. One is bringing the cervicogenic headaches into the headache line as compared to into the back pain line. And Holly Jo and Mary Beth both provided kind of operational perspectives and said that they would have preferred option 2 of integrating it into the back pain line this morning. So that's largely why the VBBS committee ended up pursuing option 2.
I see. Okay, thank you.
Any other questions from the group?
Okay.
Do you want to vote on these individually at the end?
I think, yeah. So our plan will be that we'll vote on this as a total package unless we get kind of caught up in a vigorous discussion about one or more issues, then we can separate that out for its own vote. So for the insomnia topic, we've been talking about this. This came to us in June. You heard about a lack of ability to access cognitive behavioral therapy for insomnia, or CBTI, that was brought to us by a sleep specialist. We had been trying to various options to propose ways of covering parts of CBTI. Staff were directed to look into what were the most important components of CBTI. If you couldn't have CBTI as a total package, that evidence is in your summary. The group this morning, the main gist of the conversation was that CBTI is highly evidence-based. It can be done through telehealth. It can be done in a variety of formats, and that the medications that are used have significant drawbacks and risks. And the group felt that no change to the current insomnia guideline would be preferable, that we really want to stick with the most evidence-based treatment, which is CBTI. So the staff recommendation was rejected, and there will be no change to the guideline. Questions? Okay. And then we moved on to surgical treatments for obstructive sleep apnea. This came to you in June as a coverage guidance. You approved the coverage guidance itself, but staff were directed to work further on various details of how this would be implemented into the prioritized list. These included trying to define what an adequate trial of CPAP would be, how inadequate benefit from CPAP would be defined, and CPAP, how you would define CPAP intolerance. We consulted with our evidence vendor who did the evidence review and gave us information from private payers, et cetera. And we also had input from our subject matter experts. Oh, and there was additional questions also about tirzepatide, which is a drug, and mandibular advancement devices, whether they should be included. PNT was rather clear that tirzepatide, all the studies were for people who were not eligible for surgery or did not want to pursue surgery, so it shouldn't be in the treatment pathway. And based on expert input, the mandibular advancement devices are for specific patients. They shouldn't be universally used. And so those were not included. Those are two questions that you had for us last time. And then there was an additional small little change that I had kind of folded into this that came from a CCO medical director about some wording in the section on children. As a reminder, this surgical treatments was only for adults. So pretty much everything we're talking about in the guideline and for coverage changes would be for adults. There's a small little change for children, which I'll go through as we look at the guideline wording. So in general, everything was the concept of what it was in your packet and staff proposed was approved. Some of the specific wording was changed. Staff had taken private insurance coverage wording that used adequate CPAP trial to be a minimum of 4 hours for 5 or more nights per week, and changed this to be the wording that you see there, which is CMS wording, and is what we were told from our CCO medical directors who were in attendance, is what they get from the actual reports from CPAP. which is at least 4 hours per night, 70% of the nights in a consecutive 30-day period. So it essentially works out to the same thing, but this wording is consistent with CMS, consistent with earlier wording in the guideline, and is what is reported to health plans. Makes more sense. Then we had a minimum trial of 4 weeks. They changed that to 30 days to match. And then this wording change, actually, it appears 4 times, so you'll see it in several places. But otherwise, they felt that the changes that had been suggested, which were inadequate responses in AHI-4 of 15 or greater despite using adequate CPAP, inability to use CPAP has a definition now, and you've had made reasonable attempts to have any barriers addressed to CPAP use. And so you'll see that for both the UPPP as well as the tonsillectomy. And then in that one section I promised you about the children, this has actually come up from a lot of the nurse reviewers, that the way the guideline was written, it appears that children have to have surgery before they can be eligible for CPAP, which has been thought to be a bit aggressive. So we are changing it to, you need to have undergone surgery. To get CPAP, you have to have surgery and still have a lot of residual symptoms, or you cannot be a candidate for surgery, or you can prefer to try medical treatment alone. And that was roundly approved by the nurse reviewers. So a lot of little moving pieces and changes in there. Does anyone have any questions or?
I do, Ariel. Question on the tirzepatide or Zepbound. Tell me more about P&T, because my understanding is that it is FDA approved if you have an AHI greater than 15, and then it's approvable.
So we consulted with our P&T staff at OHA.
Yep.
They reported that all of the studies to date on the effectiveness of tirzepatide excluded patients with planned surgery for OSA. So they may have had a AHI that would qualify for them, but either they didn't have the anatomy or they chose not to do surgery, or otherwise weren't in a surgery consideration pathway.
So are they requiring surgery before using this drug?
No. So what they were pointing out was that they were basically 2 completely separate groups of patients. You either went down the surgery pathway or you went down the drug pathway in the drug trials.
Okay, so they're still approving the drug for patients with AHIs.
Oh, of course. Yes. Yeah.
Okay, that's where I was going.
They just didn't want them to be, you need to have tried and failed the drug before you can do surgery. They felt that wouldn't be appropriate.
Okay, got it. Okay, thank you.
Oh, and I failed to mention one additional thing we talked about in June. I was asked to look at coverage of DICE, the drug-induced sleep endoscopy. We just reviewed that about a year ago, and the question that you all asked me to look at, which is how often does it change surgical management? We had found that the evidence showed that there wasn't really overall in the general population, there's not a change in medical management using DICE. We did hear this morning that is not the experience of our subject matter expert in his practice, but that's what the published literature showed.
So before I think I see people getting ready to jump off mute and ask questions. We do have one of our invited experts on the line. So Dr. Libby is present. I just wanted to give him an opportunity to make any comments as he's been working with staff on these edits. Dr. Libby, are you there?
Dr. Libby, you'll have to unmute. Thank you.
I think I have unmuted now. Can you hear me?
Yes, we can hear you.
Great. I appreciate the discussion, and I don't have any experience with a GLP-1 drug since I've been retired for about 3 years, and they were not used for sleep apnea before I retired. So I can't really comment on that. I've reviewed the literature a bit, and they do appear to be effective. But I certainly would recommend a trial of CPAP before going on drug therapy, literally for the rest of your life. Other comments? I do think, although again, I have no experience doing DICE, the procedure where you watch a patient asleep with a scope down their throat. But I do think it's probably in evolution and will be valuable in the future. But I don't disagree with the literature review that shows it doesn't change outcome in adults at this time.
I'm sorry, yeah, and thank you for that clarification. It doesn't change outcomes in adults, but it does in children. We already cover it in children.
Right.
Cool. Cool.
Thank you so much for being here, Dr. Libby.
Sure. Glad to answer any questions as they come up.
So I'll go back out to the commissioners. Are there any questions from
Oh,
the
and
commissioners?
Leslie, I'm sorry.
No, go for
I
it.
wanted to call out to you. You had asked for consideration for patients who needed a caregiver help. So there is wording in there now. If you don't have a caregiver who's available and able to help, that would, for CPAP, that you wouldn't need to be required to use CPAP.
Great. Thank you so much. I appreciated that call out. Thank you.
Back out to the group. Any questions or I guess comments, questions for staff, questions for Dr. Libby? Okay. Hearing none.
All right. Then we can go on to basivertebral nerve ablation. This is a procedure for a specific type of
Page
low back
253.
Thank you.
of low back pain that is caused by nerve a particular type of nerve pinching. The staff evidence review did not find significant difference in published literature since the last time we reviewed and found it to be have an ineffective evidence of effectiveness. There were a couple of small cohort studies that had been added to the literature, but nothing that changed previous staff recommendations. We did have copious amounts of submitted literature, and those were you'll see the disposition of those in your materials. We heard testimony from Dr. Ray Baker, who's the Chief Medical Officer by Boston Scientific. He testified about the effectiveness of this treatment and noted that the trials don't have long-term data that's not crossover, meaning the control group got the treatment procedure because the treatment showed superiority by a certain period of time, and they didn't feel it was ethical to continue to withhold the treatment. And he noted that it has, in their studies, it shows durable long-term evidence. The final decision by VUS this morning was to continue non-coverage and because of continued insufficient evidence of effectiveness. Any questions about that? And then we went on to anterior tibial tuberculoplasty. Sorry, I mangled that. Katie, you can correct me. This is a knee procedure that we exclude because it was reviewed and found to be a type of procedure, the maquette procedure that's not used. We have been informed by knee surgeons at OHSU that the same code is used for procedures that are current practice. So we are moving this to the knee condition line and removing it from the excluded file. You can let your colleague know, Katie.
Yes, wonderful. Thank you. No, this is a tricky thing where unfortunately the description of the code uses a version of the procedure that really didn't work, but the same essential procedure with slight variations is quite beneficial. And so it's a code problem, but this is correct. And thank you. And there are a couple of people hanging in the balance of this right now, patients who are going to get much needed surgeries now. So thank you. This is correct. Thanks again.
Well, they won't get it till 10/1/25, but.
Well, they can appeal though, probably. Yeah, we'll work on it.
Yeah. Then we talked about BioFire Spotfire. This is a very specific machine, proprietary machine that can test for multiple bacterial and viruses that can cause either sore throat or upper respiratory infection. It uses a PLA code or proprietary laboratory analysis code. There are very similar lab tests that use generic CPT codes that we currently cover that have as many. There was some discussion this morning about that the BioFire tests for too many organisms. So it's sort of a larger than necessary test, but we do cover similar codes that cover as many or more entities. And the group overall felt that we should add it to the diagnostic file for use when groups feel, a clinician's office feels it's warranted. We talked about interspinal spacers for lumbar stenosis.
Hey, Ariel, quick question. Can you hear me okay?
Yes, yeah.
On that BioFire test, and this comes up in the hospital, is that these tests are overused and they don't affect treatment. For example, as we know, the AAP doesn't recommend testing for bronchiolitis. We already have group A strep tests. So we already have tests. These tests generally are overused. And since they're, I believe, non-CLIA, so they're marketed for practitioners. And so it dramatically increases the cost. So I'm not in favor of these tests. And I hope we have some more discussion on these because this will dramatically increase for testing that we do not treat.
So let me go back and give you a little bit more detail about the BioFire Spotfire. This is a test that tests for Bordetella parapertussis, Bordetella pertussis, chlamydia pneumonia, mycoplasma pneumonia, group A strep, adenovirus, COVID, rhinovirus, RSV, all of these things. There are other tests, either types of tests or even just codes that test for, say, influenza or COVID or RSV, influenza and COVID together. So just the 3 or 5 agents. So there's a wide variety of other tests and other codes that are available. Currently on the diagnostic file, we have some CPT codes that are respiratory virus panels that do 6 to 11 targets or 12 to 25 targets, as well as the specific, one agent types of tests. The BioFire Spotfire is a machine that you would have to buy, and then you have to pay for the panel, the cartridge or whatever they do to run whichever panel you want, the respiratory panel or the pharyngitis panel. There's one study of it which essentially shows that it's effective at finding the things that it is saying it's finding. So it agrees with laboratory run tests. It was approved by the FDA in 2024. The cost for this is reported to be between $125 and $602 a test, although we heard this morning from at least one of the medical directors that they felt that that was a low estimate. Single agent tests, for example, for COVID or flu are $25 to $50 a test. Respiratory panels, for example, Quest has one that they market for about $1,000 to $1,500 for the panel. And the other panel tests that I had mentioned that were the up to 11 and then I think 11 to 25, they are $152 to $291. So we did talk this morning about concern for overuse. They're both overused overall. There's a question about whether they change management. There's a question about whether there's too many targets, and whether we need to, you might want to know if someone has flu or COVID because we have treatments for those agents. The literature does talk about, if you can be a positive virus, maybe you can reduce antibiotic overprescribing if somebody can be shown that they have a virus. But yes, there was some concerns that if we cover this PLA code, we'll have other PLA codes, et cetera. But I think overall, because we cover current panel tests up to 25 pathogens, and this is another form, the group this morning felt that it was most appropriate to open these on the diagnostic file, but there was definitely a couple of folks who expressed concerns, and I am more than happy to hear other concerns that folks might have.
And Ariel, are those other tests, are those like the PCR panels, are those performed in the doctor's office or are they sent to a lab? I guess that's
As far as I know, they are lab run tests.
Correct. And this is an office test. So my feeling is that this will be directly marketed to providers, and this will dramatically increase over testing due to the marketing and ease of use. And that's what we've seen in the hospitals.
I have a question, and that is, what's the prevalence? So, regarding Mark's concern, what are the most prevalent things that come up in this test? And is there some other test that would better cover the things that usually show up?
So we have individual tests or other panel tests for all of the things that you would find in the BioFire Spotfire proprietary test. And what you, I don't know what we, at least in my personal experience, you typically want to know about the things that you would like to treat. So influenza and COVID being the most important, and group A strep for pharyngitis, because those are, we have effective treatments that might change somebody's outcome, depending on their clinical situation.
Right.
I know in the ER and hospital setting, some of the viruses, especially for small children, can be important because of bronchiolitis and things like that. But Ben, you have your hand raised.
Yeah, I think the only reason that we will test for those for the respiratory viruses that are not influenza or COVID are for cohorting if kids get admitted. To understand precautions, respiratory precautions, etc. I would never. I don't know that I would trust this for strep throat. And in general, we shouldn't, as pediatricians, we shouldn't be testing people for pharyngitis unless we're going to treat, which really is then about group A strep. Pertussis. I agree with Mark. I think I think there are better alternatives, and this is going to lead to a lot of over testing and unnecessary testing. I don't see the value, and I would rather have people have to think about it as opposed to just shotgunning things and getting results that may or may not be false positives or false negatives. My guess is they did not really look at this on young kids.
What might be the cost of?
Actually, the one study that they did that was published that led to FDA approval was testing against standards. So a known sample of parainfluenza or a known sample of COVID. There's no test for how well these perform in the community in practice.
Right. I mean, there's no reason I need to know if it's parainfluenza unless the kid's getting admitted and I need to worry about precautions.
I have a question just to see, is there any benefit to like rural areas or underserved areas for this device? Or is it really doesn't have any benefit to some kind of certain like special situation?
Does it change your management?
Does it increase access to testing if it doesn't have to, like if it's in the office?
Most people do like the in-office strep test.
Yeah. Okay. So there's really no benefit to.
And then flu and COVID
they're rapid anyway.
So you do a rapid.
So it's all rapid. It's all easy. But it just seems to go against our other kind of policies of accepting all diagnostic tests, right? Like we pay for almost everything, any diagnostic kind of thing?
No,
okay.
We pay for medically necessary and appropriate diagnostic testing, and I think they're arguing that it is not medically necessary and appropriate.
Not approving. It doesn't sound like.
Heidi, were you trying to say something?
Yeah, I just wanted to clarify that this is a molecular platform, so it's a little different than the point of care antigen testing. So there are some differences in the test characteristics. So just to make that clear.
So, couple questions.
This is Chris. One of the, oh, sorry, go ahead.
Oh, go ahead, Chris, and then we'll have Larry.
From the discussion this morning, I kind of had some of the same thoughts. I guess what I heard was it's one of the many options that falls within the same price points as what's currently on the table. And so it's one more option. The other one is because it's that molecular option, it is equivalent in effectiveness. So it was just it wasn't the overuse wasn't necessarily the challenge. I guess my question to you guys is, do you see that RSV is going to be any different?
We have a test for RSV that is, I know that gets run a lot on small kids in the winter.
Mm-hmm.
So.
And
Maybe
RSV
I'll
is
try.
not recommended to be tested during bronchiolitis season.
We will screen
Well,
early in the season and late in the season. It can be useful when you're looking at, when the prior probability is much lower. But it doesn't impact therapy at all. And again, if you're admitting a child to a hospital, knowing their RSV status is crucial for knowing their precautions.
Right.
But that is a kid who's getting admitted to a hospital, not somebody who's being seen in an office. Or
Yeah, and I
not
think
the
some of the
responsibility of the
concern
office.
this morning was that kind of that point that this is a office-based test, and would we be driving more use because an office would buy it and then want to run it?
Yeah. I feel convinced by the, it'll push towards overutilization without additional benefit for the money spent. So that's what I'm hearing.
So I'll just, so I guess
Is there
I'm gonna want to be like cognizant of time. I'm gonna jump in for a moment. I want to be cognizant of time to keep us moving. So I guess what I'm looking for from the group is that, are people ready to say we have enough information today and we're ready to vote? Or are there specific pieces that we need in order to feel comfortable to make a decision? So, and I'll just reiterate that I think that the biggest, or I'll come back to, I think, highlight something that was said by Chris, like some of the reasons that the VVBS went ahead and approved this recommendation is at least some of the medical directors felt like there were already other options in this space that we were already covering. And so therefore, to be consistent, that was where this decision lied, not in some of the concerns that are being raised, because I think some of the concerns that are being raised in this group are very consistent with pieces of that conversation this morning. So with that information, I guess what's my question? Are people ready? I'm looking for whether people are interested in making a vote today, or if there's specific things that staff can go back to the table to help people move forward.
I'm not sure if I can find you any additional information.
Utilization.
Yeah, there's not a lot of literature out there.
Expert testimony from our.
This is Chris. I guess what I heard this morning too was a difference between the primary care setting and a hospital setting, where it might have more value in a hospital setting versus not being overutilized and maybe not appropriate in a primary care setting. But if the whole platform is designed for primary care, then that definitely changes the way I was thinking about it this morning.
I agree with that. Because in clinic, if I'm suspecting something, I typically will do testing for strep, for RSV, flu A and B, and COVID. And the only benefit that I would see for this potentially would be to not have to prescribe an antibiotic.
Marcus, I see your hand raised.
Hey, Earl. If it's helpful, there was a report that Med did for my state that I asked for. It's a little bit old now from 2020, but I can send you that because there are some studies comparing the viral panel testing versus other methods and any impact on outcomes. I don't have it at my fingertips, so I can't tell you the results, but if it's helpful, I can send that to you.
Yeah, that might be a little bit conflicted because some of what we were talking about are lab tests that are panels. That would be probably what the ER and the hospital would be doing more. But yes, thanks, Marcus.
This is it's the same. It's the molecular testing, the multiplex viral panel testing. That was the ask of Med at the time.
Is there a competitor to this test?
There are other, I don't know if there's a specific in office, but there are other tests, whether they need to be run in a larger lab, or I don't think there's anything right now that can be run quickly in the office.
And that would cover the same things that are covered by the BioFire Spotfire?
The laboratory tests would cover it. Heidi, I see your hand up.
Yeah, I just wanted to add one more piece of information that I don't think I heard this afternoon in the discussion. There was a question about potential rural benefits. So one of the other things that comes along with the ambulatory testing like this is that there are aggregate epidemiologic reports for the geographical location. So sometimes that can be useful when there's limited public health information and you don't have a lot of sentinel testing happening, particularly in rural environments. So this particular type of testing also has those epidemiologic reports on a weekly basis. So for what it's worth, I just wanted to make sure that that was considered given the, resource limited question.
So are you saying that this would benefit rural health or is not
Right.
necessary?
No, what I'm saying is that and I'm not endorsing this necessarily, this platform, I'm just explaining that this particular platform will provide weekly epidemiologic reports of all of the aggregate data from anyone using this platform in the area. And that gives people an idea of what's happening. So in more rural places, you may not have a fair amount of sentinel testing. So you actually don't know when flu starts. You actually don't know when COVID's spiking. You're looking at like wastewater data or something like that. So from a public health perspective, there is potential for benefit from something like this that has point of care aggregate epidemiologic data for a particular location. And I think they do it, I'd have to double check, but I'm pretty sure they do it at least by zip code, and it may be actually more granular than that. So just another potential consideration of how it could be useful in those kind of environments when you particularly have an emerging infectious disease, and a particular like flu season may start in, a number of different weeks for a particular location and may change your management if you know it's starting to happen.
Be done through analysis of sewage. I mean, I think we do that for polio
And I guess, Heidi, I would have to look at that data for population health. I did not know that this sends patient-specific data to a cloud or warehouse, I guess. Is that what you're saying?
Yeah, so my understanding, so I had talked to them about it because I was trying to understand, this was actually a few months before I started with HERC, but was trying to understand it for a public health reason. And what they told me, and they showed me a couple sample reports, is that there's this aggregate data showing which pathogens are, trending in this particular area. And it's like a weekly report, similar to what we do for other sort of epi trends in the public health world. So that's kind of what they shared. I don't know how that plays out in real life. I've never used that myself, but they do have those reports.
to be quite frank, that sounds like a sales pitch.
It could be. I'm just sharing a potential, what kind of data they have.
Can I suggest like maybe we not necessarily a formal motion, but maybe we do a quick straw poll to see where folks are sitting and seeing if there is a particular momentum one direction or the other. I'm just hearing a lot of different thoughts and dialogue and not necessarily coalescing in a similar direction. So why don't we straw poll and then we'll go from there. Daphne, do you mind straw polling?
I do not mind at all.
So I guess the question that I'll kind of put an informal motion on the table would be that the VBBS recommendation is to adopt the staff's recommendation to add this to the diagnostic procedures file. So if we were to vote with a formal motion, I'd be interested in whether people are leaning towards yes, leaning towards no, recognizing that it's non-binding.
All right. Mark, which way are you leaning?
Deny.
Stacy?
Approve.
Ben?
Deny.
Lisa?
Deny. If we could add it to just hospitals, maybe approve. When we
Larry?
can't, then deny.
Larry?
I'm leaning no, but I would like more information.
Chris?
Approve.
Katie?
Deny.
Leslie?
Approve.
Pretty split.
And Adrian?
Adrian. Doesn't really matter.
I didn't keep count.
Real split, maybe we can come back.
So, okay, so why don't we do this? So,
Do you want me to work with Marcus Vancouver and get any other background information that I can find?
I think that would be great.
think that would be great.
I also think it would be helpful if there were a couple different options on the table, like one that would look at just hospital usage versus others. I heard that from the group a little bit too.
I think that's also a good idea.
Yeah, so we can talk about the setting, we can talk about the public health implications of this testing and reporting, we can talk about the cost issue. Leverage possible ways of utilization management, if it's the case that it's appropriate in some cases and not appropriate in others, and bring that all back.
I also would like a very specific piece of information if it's available, and that is, does the use of this test help to avoid inappropriate antibiotic use? I don't know. I don't know if I don't know if that.
Study. I mean, that would be lovely.
Yeah.
Okay.
If that information is available.
So if we're going to, does tabling a topic require a vote?
We can just have a motion at the end.
Yes,
Okay.
if you approve.
Motion.
It will be tabling this and everything else.
Okay.
Motion to
And any
table
other
and get more
changes you all want
information.
Okay,
Motion.
we will circle
motion-
back at the end, Dr. Lyon. I don't need a
Okay.
motion right now, but that the intent, I think, is no.
Great.
I'm just,
I'm good at capturing aerial mid-task.
yeah, sure, that in my minutes, I flag that there's when we don't follow the BBS recommendations, I always try to flag it in the BBS minutes, so.
Extra kind of.
Yeah. So where were we? We were talking about interspinal spacers for lumbar stenosis. If you have questions about this was Heidi Gullett did the evidence review. The recommendation was to continue non-coverage, and if you have any discussion or questions, I would refer to Heidi. And then the next option was blood-based colon cancer screening. Just to draw your attention, this was the first time we used our second evidence vendor, RTI. So that was the evidence report in your packet was generated by RTI. Based on their
And that's page 294.
and HERC staff work, we are recommending non-coverage and the appropriate changes, et cetera, that we need to do to make that show up on the prioritized list. Any questions about those issues? Okay, then we talked about ENT. So now we're working on benefit update projects. So just to remind you all, this is not effective unless I say differently until 1/1/27. That said, the first thing we talked about was our PE tube guideline. You all had
Page 317.
had wanted to approve it in June, but wanted to have a version that you could implement earlier. So there was a version of the guideline that could be effective 10/1/25 that was approved this morning. No other changes from what you saw and were comfortable with in June. The tympanic membrane perforation, we did, this is a little hole in the eardrum. Usually they heal by themselves. We currently only cover them if they cause hearing loss. The recommendation is to create a new code grouping for 1/1/27. It would allow treatment for, well, the staff recommendation is for 2 conditions, hearing loss and recurrent infection.
Page 332, sorry.
BBS made 2 changes to what's in your meeting materials. They defined recurrent infection as being 3 or more inner ear infections in 1 year. And then they added a third indication, which is you can repair the hole in the eardrum if you're taking out PE tubes. This is actually pretty common for the nurse reviewers, and it was a request on the nurse reviewer side, and we all thought that was appropriate. Any questions? You can see that the wording that's highlighted behind you was what was changed from your meeting materials.
Hey, Ariel, how do they currently do it when they take out the PE tubes? Do they repair the eardrum in all cases?
No, but sometimes they, there's, I don't know, I have seen this. It seems to be a somewhat requested thing, especially if an ear tube's been in there a long time. I don't know.
Most often it heals, the eardrum heals on its own. And there's a small proportion of times when they need to go in for tympanoplasty afterwards.
But they don't do that for all when they take out the PE tubes, correct?
No. I mean, most of the time PE tubes come out on their own.
Okay, again, I was just looking at this, the guideline notice, when performed during ear tube removal. I guess that's not implying that it's always going to be performed, just if clinically indicated would be my guess.
Do you want to, we could modify that, ear tube removal when clinically indicated.
Well, I mean, the beginning of the sentence, repair of open wounds or perforations in the eardrum.
So I heard from Ben that if it doesn't heal, then you would repair it. But our guidance sounds like the opportunity to repair it is when you first take it out, which would be before you know if it's gonna
Well,
heal.
sometimes this happen because you've had a severe inner ear infection and you've had, your eardrum rupture is kind of the layman's term.
Yeah,
And so it's not where the PE tube is, it's a separate place. Sometimes they'll repair
I see.
when there's more than one type of.
I see.
Right. It
Yeah.
generally does not happen when the tubes are being removed, because like I said, most of the time the tubes fall out on their own. It's usually from chronic repeated eardrum rupture or trauma. We see that with Q-tips and all sorts of other things that people put in their ears, and rarely after rarely after PE tubes.
Okay. Yeah. Pediatricians are happy with this. I'm happy.
And in many cases, it doesn't make sense to put the kid under twice.
No, of course not. Yeah.
Okay. People are okay with that? Okay. And then tonsillectomy, and there were no changes from what was in your
Page
meeting.
334.
And then the other ENT issues.
Page 340.
Again, no changes from the staff recommendations. And then we went on to the BUP podiatry or foot topics. I know we have somebody here to testify. I'm just going to kind of summarize all of the decisions and then we will welcome you up to give testimony. So we talked about some general podiatry conditions. There was some more clarifying discussion, and I think everything was accepted as presented. We talked about bunion and hammer toe.
Sorry, except the hammer toes.
Yeah, so for bunion and hammer toe surgery, everything was accepted as what's in your packet, except a friendly staff amendment. There was one hammer toe release code that had not been included, and there were a couple of codes that were added to this new high-risk code grouping that weren't continued on their previous covered line, and so those were changed. That was all approved. So basically just a few coding details that were friendly amendment. Staff agreed, but they were late recommendations from our subject matter expert, Dr. Superling, who's a podiatrist.
1 through 7 on 370 and 371.
So these BUP topics, remember, have big tables of codes because of all of the BUP code movements. So it's in the last CPT code table.
So it's on page 372 is where the table is.
Okay, yep, I see it. Thank you.
And the intent was, there's no change in the intent to add coverage for high-risk feet for people who have bunions and hammer toes. It was just making sure we were complete with the codes that we were including, according to our expert. Maybe I could try and just email you my copy. It's got the changes.
Are you comfortable based on that, Dr. Lyon? Or are you still looking?
No, I'm okay.
Okay, great.
Does anyone want to see the actual codes? They're in, I just sent it to Liz to put up on the screen. They're highlighted.
Sounds like it's all right.
Okay.
No.
Then we talked about plantar fasciitis. Essentially, no change from current coverage. The evidence shows that other treatments are not very effective, including steroid injections, surgery, and orthotics.
That's
Same
page
with
378.
Similarly with
Thank you.
plantar neuromas, the evidence shows that
387.
a lot of the treatments aren't effective. So basically continuing current coverage, which would basically mostly be office visits. For orthotics, the main
396.
change here, to back up one step on orthotics, there is an Oregon administrative rule that limits orthotics to people with diabetes. And then there's a whole other set of orthotics that are for things like foot braces and people who have amputations and need something. All those specifics are in that rule, but general, kind of what you would consider sort of general orthotics are limited to type 1 diabetics. We're having a guideline that will kind of expand that to people with high risk foot conditions, which could be diabetes, it could be peripheral neuropathy, it could be peripheral vascular disease, people who have high risk feet. And we will have to work with OHA to revise the rules. So this may or may not be effective 10/1/25. But you can see the proposed new guideline, which, and we're continuing the other Oregon administrative rule for those parts that are part of prosthetics and the other highly detailed kinds of things.
Great.
But any questions about any of the ENT or podiatry issues? And then we have public testimony. So, would you like to come? So I know that you've been presented this morning, and I apologize, it's a new group. So if you need to state your name again, that you are representing yourself, if that is still true, and any financial conflicts of interest, and then you have 3 minutes.
The owl will what?
Will it? Okay. Yeah.
Yeah. Okay, good. No worries.
Do you mind? Do you mind terribly if I read the statement?
Go ahead.
Go ahead, Daphne.
Thank you so much. This topic may be a sensitive discussion for some, and as a reminder, HERC is a policy-making body and can't make decisions about coverage or care for individuals. Any policy changes that result from today's discussions go into effect at a future date. These discussions can be intensely personal for some, and yet in this forum, we tend to discuss subjects in terms that seem clinical and impersonal. Not every person's experience will fit into the picture that the clinical evidence shows. Please be aware that our commission's business is to make the best possible decisions for the general population using HERC's methodology and processes to determine the importance of services. So we're putting up a timer for 3 minutes, and a progress bar will show how much time is remaining. Please stay and be available for questions in case any members have that for you. If you would state your name, any potential conflicts you have regarding this topic, and the floor is yours. Thank you for coming.
Thank you. My name is Lynette Joel, and I've been denied surgery. And I can't wear shoes. I can't wear boots in the winter. I don't have diabetes, but so I don't qualify. This has been going on for several years. They say that bunions are a bony bump on the side of the toe, which is bull. It's actually your joint twisting inside out. And like I mentioned earlier, it's like climbing a ladder with a dislocated shoulder is what it feels like when you're walking on. And it pinches so bad, and it hurts really, really, really bad. They say to wear wider shoes. No, that's bull. They don't make shoes that wide, period. And anything that even touches top hurts. Blankets hurt. If they burn, And, but I don't qualify for surgery, even though it's affecting. I've had ankle surgery. I'm going to have it again because I can't have the bunion surgery. So I'm going to have my ankle surgery on it again because it's messing it up again. So that's kind of like defeats the purpose of having the surgery. And it's just, it's crazy, but why choose? No, don't work. You know, and it's not going to get better. It's only going to continue to get worse. It's not something that can get better. It might be prevented, but once it's already there, it's not getting better. It just gets worse. Right, but, and this is, I don't know what else to say, but it's very, very, very painful. It's like I've gained weight, my blood pressure is up out of the sky, and I'm going to have surgery on my ankle again. It's just, it needs to be fixed. It's not something that's going to get better on its own. And it's a preventive thing, pretty much, because, you know.
So I just want to say, thank you so much for coming today and sharing your story with the commission. So I know that you've talked to Liz and, and some other folks, and, unfortunately, like HERC is a policy making body. And so we make decisions that are not specific to individual cases. But for me personally, I just want to say thank you because it helps me remember, and I'm sure many of the other people in this room to remember that the decisions that we make do impact patients, and it helps us keep those patient perspectives at the center of our decision making. So thank you so much for coming today and sharing your story.
Thank you.
For the other members of the commission, I just want to provide a little bit of insight so I know Liz chatted with Ms. Jewell a bit, and then it sounds like maybe some of the normal things that we would say, such as connecting OHP members with the ombuds office, maybe some of these have been explored already, but Daphne has already said that she will kind of connect with Ms. Jewell when she is back in the office on Tuesday, so we can make sure that all of the potential vehicles have been explored to provide a solution for you.
Okay, thank you.
Is there anyone else from the commission who wants to make a comment or ask a question? But I did want to just kind of relay that some of the groundwork that has been done to move this forward.
I would personally like to talk about there's 7 qualifications and they're all ands.
Okay.
Yes. Yeah, I mean, I would like to open that up, but first I do want to validate your point that it's more than a bony bump on the head. And I think we have a section in plain language, and then we have a section in more descriptive terms. And so we do have that at least in there that, I mean, it's an angulation, the joint is not in the right orientation. So yeah, I want to validate that.
Yeah,
For you.
and we apologize if any of our materials seem dismissive.
Thank you.
So Dr. Lyon, I see your hand up. Is this for a question for Ms. Jewell, or is this for the topic in general?
It's for the topic in general.
Okay.
My question is, are there other types of devices that can be used to help someone having difficulties that are covered that are not called orthotics?
No.
Yeah, those would be sort of like the shoes and pads and things like that, but I'm not sure that we cover those specifically besides just
they don't
recommend.
If someone is having difficulty walking, or is it much higher risk of falling because of a problem with their feet? Is there any other way that some type of device that could be helpful would be covered?
No. Just
that's a problem. That's a problem because someone falling can require more care than if they were to get something that would help them better balance and stand and walk.
Daphne, I
Larry.
see your hand up.
Oh, I do want to, Larry, just.
Wait, Daphne,
Mark, I'm sorry.
Daphne's hand has been up for a while.
Oh, Mark, go ahead. I'll talk after you.
From the insurance standpoint, the denials would go through the medical director. And if there is exceptional circumstances such as falling, or other exceptional issues, then there's always pathways to approvals. So
Okay.
I would not say it's a blanket statement. I would say that that's in general, but however, all of them are looked at. And if the primary care doctor specifically states risk of falling, infections, etc., then insurance, all the CCOs will look at all of these individually.
Very good. Thank you for that.
Yeah, of course.
Been there, done that.
Not here at the end. I hear you.
Thank you, Mark. I just wanted to say briefly that I write the plain language, so if I use the wrong terminology, that's on me. Sorry about that. And also, this very day, I have an appointment after this meeting to start talking to people about what we can do for you. So that is in the works, and I'll get in touch with you on Tuesday. Thank you.
And you are welcome to hang out and listen to the conversation. It sounds like there are people in this room that may be interested in going a different direction than the BBBS committee went this morning. So you're welcome to stay and listen to the testimony.
You're not required to.
But you're not required to. You're also allowed to leave, is what I'm trying to say. And just Daphne will be in contact.
Feel
Tuesday.
welcome.
Yes.
Yeah, Lisa, you had some concerns.
Sure, and so I'm not the expert in this, at all. When I read a list of 7 things and all of them have to be present, I'm just wondering, because I'm just looking at some of these on this list, and it feels like there would be a small percentage of people who would fit into all of those categories, and that it might be excluding reasonable and necessary care. For example, I mean, I understand the skeletal maturity, obviously, like that's okay. But number 2, you have to have risk factors like diabetes, peripheral neuropathy, and current or recent history of an ulcer or infection because of the bunion. To me, those are like, I'm just wondering from my perspective, those look like either or. You have these kind of like, you're predisposed to have complications. You've had an infection already, or you have diabetes and peripheral neuropathy, so you don't feel it, you get an injury. And then also, number 5, bunion is causing significant functional limitations. To me, that is, it feels like that would be something that would push it over the edge to be reasonable and necessary as far as surgery, but I'm not versed at all in outcomes, or why exactly each one of these needs to be met. So I'm very happy to hear from anyone.
So 3 of them are exclusions where, like, so not being skeletally mature,
Right.
not having adequate vascular,
That
blood
makes
flow,
sense. Those are hard
or
stops.
having significant arthritis. The surgery is not going to help.
I had a question on that. Number 7, it says no evidence of degenerative changes. No
But
evidence.
that's in the joint. So a bunion is the bone is but you're
Yeah.
not seeing like severe arthritis in the
Okay.
joint because in the bunion surgery doesn't.
Yeah, it
work.
would like just fuse, maybe.
And the current wording was what the medical directors reported to us that they're doing pretty much automatically as exceptions now.
Yeah.
And they strongly
Yeah.
felt that that's a group that is
So those 3.
so clearly
Hard
needing
stops.
it.
Okay. Okay.
And having a bunion or a hemorrhage doesn't mean you're gonna have a problem.
Of course.
So it's like you have to have
Of
a
course.
risk factor, you have to show that it's causing you a problem by
But they're all
causing an ulcer.
ants.
Yeah.
I
they're
could
all ants.
understand some ors with the risk factor. So like the three hard stops, you know, skeletal maturity, adequate vascularization so you can at least heal. No evidence of degenerative change. I mean, like, if that's how it's understood, then sure. Are there any ors that we can get? Yes. Okay, I want to open it up to discussion.
Yeah, I definitely agree that this isn't right, the way this is stated. For example, you wouldn't be a candidate for elective bunion repair if you actually had an ulcer or infection. A surgeon would not
No
do
current. Yeah.
that, right? So that like doesn't make clinical sense to have it stated like this. So right, I agree that this needs review and revision. I don't know if we're going to specifically like wordsmith it right here now or if we want to send it back. But as stated, I would not approve this or promote this as the statement. I do think that, the patient has diabetes, peripheral neuropathy, or other conditions that place the patient at high risk for foot complications. I mean, I think our public testimony example would meet that criteria, but might not have an active infection, right? So I think that there are some ors that might be the simplest solution to change some of the ands to ors.
Stacy, your hand is up.
Yeah, again, not my area. I'm kind of at the other end of the body, but but one of the things listening to Miss Jewell's testimony and just thinking through this is just if there's severe chronic pain resulting from some of these deformities combined with mental health, I can't imagine what it feels like to not be able to find shoes that fit the feet. So not mental health and pain is the sole criteria for allowing the surgery, but I don't see any consideration regarding those kinds of parameters of health.
Yeah, and I know we had previously talked about like chronic pain and that a lot of the discussion had then been about how that is very subjective and hard to kind of quantitate. I'll defer to Mark on this one, but I think the mental health issues would be a comorbid condition.
That's correct. If there was clear documentation from the primary care or mental health provider that this is causing a comorbid condition, that would by definition be above the line and need to be taken into consideration. And that's what I want to be clear is there is multiple exceptions as long as it's documented from the providers.
And regarding the pain, I know it's hard, isn't it? Because it is, and it's subjective. It's what the patients, what they tell us. But we also have specialists in pain, that could make evaluations and perhaps substantiate some of the complaints. So I would be in favor if with a lot of humility, but just adding in some of these other things that address other aspects of health, so that the patients are not so debilitated that they can't function or they're requiring large doses of opioids. That's not a good thing.
So I have a queue. So I'm going to go Lisa, Katie, Dr. Lyons, Leslie. So that's the order.
That's good, because I'm gonna kind of address the last thing that Stacy was talking about. So I'm wondering if the functional, right now we already have a line that says the bunion or hammer toe is causing significant functional limitation. And I would add including difficulty with footwear or something like that. And I almost think that could help with part of the mental health of it, because you can, the inability to move and function and ambulate, everything can snowball without being able to be active. And then my question about the chronic pain, and I can't answer this, is does the surgery, is it effective for just a chronic pain component, or is it more effective for the functional? And I would say put on the line whatever it is, the part that's that has evidence for the surgery, benefit from the surgery.
Katie, you're up.
Yeah, so I still think this number three deserves some specific call out and attention. Again, much of elective surgery is not considered if someone has an active infection, so it's actually invalidates you from being a candidate. Possibly the hammer toe correction is and they might do a hammer toe correction in the setting of infection, but again, that's a terrible idea to elect a surgery when someone has an infection. So this actively like doesn't make sense medically. Like from a surgeon standpoint, the way we have this listed is not medically correct. I do think that the statement on number five about causing significant functional limitations is really good. I think we can further define it or take the definition away, take all of the parenthetical statements away. Do not add parenthetical statements about shoe wear, but acknowledge that somebody who can't wear shoes has a functional limitation. So I think the functional limitation statement is really good. But again, requiring that somebody has an infection before they have elective surgery, that does not make sense. Three should be deleted. And I think if we take three out, that this gets a lot more sensible. And that's kind of my main comment here. I would say as somebody who lives in the land of, doing elective surgeries on patients and choosing when to do them, I think the verbiage we have here does give a lot of leeway and really recommends that a patient has sought other treatments, that they have significant disability, and they otherwise are a good candidate, meaning they have blood flow to the foot and the joint isn't degenerative. If their joint is degenerative, they're a candidate for a different surgery, for a fusion of the MTP joint. So that's why that's important here. It's just would be the wrong surgery to do. So I think taking out three makes this much better, and then maybe removing all the examples of functional limitations instead of adding more to it, so that that can be at the discretion of the surgeon and the patient.
So just to kind of push, I did not go through the evidence review like we did at VPS this morning. I want to call out the Cochrane review from 2024 that we reviewed this morning. They had 25 studies of 1,597 patients. There was only one study that they could find that compared bunion surgery to no treatment or non-surgical treatment. That study showed no clinically significant reduction in pain, a slight difference that they would have with very low certainty evidence about any change in function, which did not actually meet the minimally clinically significant difference for the scale that was used, no difference in quality of life, and no difference in reoperation. So
Yeah.
the surgery, at least according to our trusted evidence source, has it doesn't really show a lot of significant reduction in pain or function in the general population wide.
I can explain that if you want me to. So lots of bunions aren't symptomatic and people function just fine with bunions. So if you take that person and pit them against somebody who has significant dysfunction and then has a surgery and gets better, they're not going to look different in the end because the first person didn't have a problem to begin with. They just had a mild foot deformity, but they didn't have any functional problem. So it's kind of a weird topic to have as a Cochrane review when a lot of patients who have this, foot morphology don't have functional limitations. A lot of people have pain-free bunions, which is why it's careful to have, to have some stipulation. The surgery should not be done cosmetically. Really, that's what we're trying to avoid is patients having cosmetic bunion surgery because most patients with bunions don't have pain or dysfunction. So it's a weird topic for a Cochrane review. I'd say it's maybe an inappropriate topic
I
for the
would have to
Cochrane
go
review
and look at the
methodology.
underlying study. They may have all been symptomatic, but treated one way or another. I don't think you can assume that the group that didn't have surgery was asymptomatic. I think, but again, I would have to go pull the underlying studies and find their inclusion criteria.
It sounds like we should do that.
Yeah, we should table this. Plus we have the hammer toe codes that we can like put in there.
Yeah.
So Leslie, you've had your hand up for a long time, but maybe I'm gonna end comments after you.
Yeah, sounds great. Thank you. So I just wanted to kind of echo what Dr. Sable was talking about as well, related to number 5 in that list we were just reviewing. Really just ending it with the the patient needs to have functional limitations. I think the more detail you get into, the more likely it is that something would be missed. I mean, in the end, the intent is if they have functional limitations, and that could include ambulation, it could include MRADLs or self-care or whatever. But I think just keeping it simple that they have functional limitations is a good stopping point, because it might look different for everyone, what that limitation looks like. So I think that was my one comment. So thanks so much.
And Larry, I know I skipped you. Did you have a quick comment? I know we're starting to run short on time.
Just a very quick comment. I'm looking at health from a utilitarian perspective. And if this is something that will help someone be more functional, be able to work, then that makes perfect sense to me. And I really like what Dr. Schabel said.
I did have my hand up.
Go ahead, Mark.
Oh, okay. Just to clarify on number 3, I don't think surgeons would operate at the time of an infection, but that could be switched to a history of ulcer. And from the insurance approvals, that's what we see is they have an ulcer, they heal it, it's healed, then they have their bunion surgery. So I think more appropriately, it would be history of ulcer, not has an ulcer.
Thanks, Mark. And I apologize. I'm now seeing the hand. It blends into your background.
It does.
But like that would be one of the criteria, but not every single patient is going to have a history of infection.
I'm not against the and. I just wanted to clarify the number 3. They shouldn't have an ulcer to get surgery. History of ulcer.
Yeah. Are there pieces of this that could get approved, or just table? I think we should table all of that.
Okay. So in the interest of time, I think we're just going to table this rather than try to even move forward on any of it. I've watched Ariel frantically type a bunch of notes of things, and we will, I say we, Ariel staff, will do the best to address, and we'll bring this back at a later date. Is that the end of the report?
Do we need to vote on that, or?
So the motion, if you would not object, is that you would approve the BBS report except tabling bunions and hammer toes and
Fires.
fire to be brought back to a future meeting.
I'll make a motion for that.
Do I have a second? Sure. Lisa's the second.
We ready for me?
I was just looking at the comment that came through. We can make did you see the comment, the transcripts come through?
So Katie's asking, did VBBS hear from the foot surgeons, podiatric and orthopedic surgery?
Yes,
We did hear
he was here.
from Dr. Suferling, who's a podiatrist.
We got one public comment from the Podiatry Association that was discussed this morning.
But I don't think we've heard. Oh, sorry.
What did they say?
As I recall, he wanted more, but was glad to be making the small expansion that was in the meeting materials.
Okay.
Are we done with bunion?
What?
Are we done with bunion?
Yes, so just to clear, yeah, so the bunion hammer toe item within the current motion, the spot fire, biofire, spot fire, and then the hammer toe bunions topics have been tabled. And then we will be voting to approve the rest of the VBBS report. And so I had a motion and a second, opportunities to pull those back if my primary and secondary motions weren't fully sure what they were making motions on. Yes, Larry, I see the hand.
Is there anything else from the VBBS that we need to additionally go over today, or is that it?
That is the end of the VBBS report.
Great, thank you.
So Daphne, will you go ahead and
Happy to. We'll start with Mark.
Agree.
Stacy.
Approve.
Ben.
Approve.
Lisa.
Approve.
Larry.
Approve.
Chris.
Okay. Approve.
Great. Katie.
Approve.
Leslie
Yes.
and Adrian.
Approved.
Motion passes. Thank you.
Okay. On to the EGPS committee report. Who's doing that?
That'll be Ariel as well.
Okay. Thanks for coming. Give us a moment. We're on to the EGBS subcommittee report, but we'll give Ariel a moment.
Sorry, I'm trying to make sure I have all the notes. So EBGS met in June.
Page 406.
They went through the benefit update project, gynecology and dermatology topics. The first topic that, so this was not discussed at BBS this morning, obviously, because EBGS had already gone through and made all of their inputs. So we talked about the general gynecology in February at EBGS and then in March. And then when it was actually brought to the March meeting.
Page 406, everyone.
Sorry.
Oh,
So this was
406.
actually discussed at our March HERC meeting. And there was a whole bunch of questions about the general gynecology, specifically the effectiveness of hysterectomy for treatment of dysmenorrhea or chronic pelvic pain. Those are both currently below the line with guidelines for hysterectomy. A variety of questions about benign lesions like Bartholin gland cysts. When do they need a procedure? There was also some other questions about when vulvar lesions need to be removed. There was request for additional information on post-endometrial ablation syndrome, a review of when hysteroplasty or hysteroscopy is needed to treat uterine septa, which are tissue in the middle of the uterus, and then further information about one specific ICD-10 code, which was a kind of a non-specific code, but what would be the subdiagnoses. So there are, we looked at evidence for Bartholin gland cysts. Basically, you need to treat it when it is symptomatic, and there's several different evidence-based treatments. Post-endometrial ablation syndrome is a rare syndrome that happens when you've had a tubal ligation and then you have endometrial ablation, and the definitive surgery is hysterectomy. For vulvar dysplasia, ACOG has a guideline for treatment of when to treat it. And then for uterine septa, so this is a developmental, when you are a fetus in development, there are two things that come together anatomically and fuse and form the uterus. If that doesn't happen, you can have two separate uteri, that's uterine didelphi. There's no treatment for that. You can have a partial fusion, and then you can have almost fusion, but there's a small piece of tissue left where the two embryologic pieces were. So looking at when and why would you want to remove the uterine septum? Initially, staff had said that it should be done only for menstrual bleeding issues because there can be trapped menstrual blood. HERC was very interested in learning about coverage for reproductive outcomes, such as reducing the risk of preterm birth, because you have a abnormally shaped sized uterus. So there was a systematic review in 2024 looking specifically at this. There was really no improvement in live birth after a septum was removed. There was no significant change in preterm delivery or miscarriage rates. There was a sub-study that from 2021 that they mentioned about breech presentation. The numbers were so small they couldn't actually say anything. 2 women in the group that had the septum resected were breech versus 6 that didn't have it. But cesarean section was actually higher in the surgical group than in the non-surgical group. So essentially, the authors' conclusions were that treatment of the uterine septa did not gain any improvement in reproductive outcomes. And then there was obstetric complication. There was a systematic review in 2022 that showed that, yes, the septums are related to all kinds of horrible birth outcomes, but again, it doesn't seem to help if you treat it, which would make sense embryologically because there could be multiple malformations present and you just see the septa. It's unclear. So ACOG, they only in their recommendations only address obstructed menstruation. The American Society for Reproductive Medicine, their guideline on uterine septa, they found insufficient evidence that treatment would affect fertility or infertility. And then they have some recommendations if you do decide to do treatment. So in summary, for Bartholin glands, to answer all of your questions, you can treat symptomatic cysts conservatively or with the same procedures as abscesses. Procedures to treat symptomatic cysts are standard of care. And the abscess is currently in our abscess line, which is line 204, with the appropriate treatments. Marsupialization, which is another treatment for Bartholin gland cysts, is currently on the non-covered line. The recommendation would be to cover it. So the staff recommends placing Bartholin gland cyst diagnoses and abscess diagnoses into a new code grouping, which is the benign neoplasms and conditions of external female genital organs. They would have IND and marsupialization would be available. Post-endometrial ablation syndrome, it's a very rare complication because of the order that you might have a couple procedures done causing complications. The appropriate treatment is hysterectomy. It may be self-injectomy if somebody wanted only that. So that should be what we should be covering. Vulvar dysplasia should be treated, particularly if they're high-grade lesions. The recommendation is to add that to the code grouping with mild and moderate vulvar dysplasia, to add all of the vulvar dysplasias together. You asked about N94.89, which is other specified conditions of the female genital organs. It includes erosions of the external female genitalia, hematoceles, hydrocele of the canal of Nuck, which is a fetal remnant that can lead to hernia. Extremely rare though. And you could, there's mass of the vulva, which would need diagnostic testing, suppression of menstruation, etc. Staff continues to recommend adding to the evaluation and medical management line. If it's used for that very rare diagnosis of canal of Nuck, then that could be approved by exception. There was a question about tricholoropathy. I don't even know if I can pronounce that. That was, you were asked, it was interesting. I couldn't find any references from after 1960. The majority, one was from 1884, and so it's a panacea for abnormal uterine conditions such as eversions, ulceration, congestion, and patulous os, and uterine catarrh. And then there was one case report from 1956 describing its use for incompetent cervix. So I am very confident that we can put this on not medically necessary, as it does not appear to be a current medical procedure. Unless you have uterine catarrh, then we can talk. For uterine septum, the staff recommendation has changed to recommend no coverage of routine resection of uterine septa. If it's a rare case of blocked menstruation, that can be handled through the exceptions process, and most likely that would be an EPSDT related case, because this is usually in adolescent girls when they first begin menstruation. The evidence finds that treatment of uterine septa does not improve reproductive outcomes. So that is the total staff recommendations. So we would create a new code group for this external female genital organ with, as I mentioned above, and then there'd be some guideline note changes with just the typical things, and then pelvic congestion syndrome, which we basically said is only on this line for medical treatment, since it's going to be just for medical treatment, and we don't need that guideline anymore. And similarly, chronic pelvic inflammatory conditions. You'll note that I didn't talk about hysterectomy for chronic pelvic pain or dysmenorrhea, and we're going to talk about those in a minute. So any questions about the general topics? Okay, we can go on to hysterectomy for dysmenorrhea. Just as a reminder, dysmenorrhea is
page 241.
It's pain with menstrual cycles. It's very common. Typically is treated with NSAIDs, birth control pills, etc. In heat, birth control pills, hormonal contraception, Mirenas, et cetera. We reviewed this at our March meeting. And at that time, the staff recommendation was to just move the current guideline into coverage. There was a request to look at the evidence for the effectiveness. So there was a narrative review from 2024 that again talks about NSAIDs, birth control, other hormonal treatments, GnRH analogs, which would be like Lupron to stop menstruation, heat, etc. Noticed mixed data for acupuncture, which I think we actually went over at our last meeting. Some surgical things, and then endometrial ablation, hysterectomy was noted to be a definitive surgical treatment, but reserved for patients with secondary dysmenorrhea, which would be pain with menstruation due to another cause, such as endometriosis or adenomyosis, and we have guidelines already for those conditions. There was a Cochrane review for about TENS that didn't really show significant improvement. Acupuncture also didn't particularly show significant improvement. And then there was a 2015 randomized controlled trial of pain reduction after hysterectomy for women with dysmenorrhea. It was small, 59 people were included, 31 had a hysterectomy, 28%, or actually it was total hysterectomy versus supracervical hysterectomy. Of note, the majority of patients were actually found to either have fibroids or other pathology. And they noted basically that the two procedures were very similar. Then they thought that showed that there was some symptom relief and quality of life in the women who had surgery regardless. ACOG's guideline, they have hysterectomy guidelines for fibroids, endometriosis, and adenomyosis. They also talk about dysmenorrhea in the adolescent, and they specifically don't recommend hysterectomy in that particular patient population. So in summary, there's good evidence that NSAIDs and hormonal treatments are effective, and that's what's recommended by experts. There's very little evidence looking at non-pharmacologic treatments. Acupuncture, TENS, and sacral neurectomy have little evidence of effectiveness. Looking specifically at hysterectomy for dysmenorrhea, there's only one RCT and it compared two types of hysterectomy. There was no studies comparing surgery to other medical management. And the one study, which would basically be a cohort study, because it's two different forms of hysterectomy, found statistically and clinically significant improvement in pain and quality of life, although the confidence intervals were quite large and did include the null, and it was a very small study. They did note that many of the patients actually had endometriosis, adenomyosis, or fibroids on final pathology. So the staff recommendation is to not pair dysmenorrhea with hysterectomy, TENS, acupuncture, or sacral neurectomy because of minimal evidence of effectiveness. Hysterectomy could be approved by exception if the patient does have adenomyosis, endometriosis, or fibroids. Those would be completely other, they would be another diagnosis and would have their own guidelines. So we would place dysmenorrhea in the medical management group, and we would eliminate the current guideline, which is deleted. Questions about hysterectomy for dysmenorrhea? Kind of same song, second verse would be hysterectomy for chronic pelvic pain. So chronic pelvic pain is pain in the lower abdomen.
Page 247, or I'm sorry, 427.
With an unclear cause. There are many things that could cause it: irritable bowel syndrome, depression, pelvic inflammatory disease. It could be adenomyosis, endometriosis. There's multiple things that could cause it. If you rule out all of those other causes, then you're kind of left with chronic pelvic pain as sort of an undefined condition. Treatments include NSAIDs, hormonal medications, antidepressants, medications like pregabalin and gabapentin, pelvic floor physical therapy, and cognitive behavioral therapy. Surgeries, including hysterectomy, have been proposed in some cases. You asked for evidence on the effectiveness of hysterectomy, specifically for chronic pelvic pain. There was a systematic review and meta-analysis in 2025. They looked at multimodal physical therapy, cognitive behavioral therapy, biofeedback, all kinds of different things. For physical therapy, they found that there was a statistical significant difference, but it didn't meet the mean clinically important difference for a change on the pain scale. And then 2 trials didn't report quality of life that showed statistically significant superiority of PT over leaflet and people just getting medical information. For psychosocial approaches, there were 8 studies that showed no clinically important and no statistically significant impact on pain intensity, and quality of life had conflicting results. Acupuncture, they could not make any conclusions. No difference in any intervention with psychological function or physical function. So unfortunately, the authors concluded that multimodal physical therapy may be helpful, but nothing else was significant. Nothing else was very helpful. And when HERC staff dug into their PT, it was statistical and sort of marginally clinically significant improvement in pain. Then there was a Cochrane review in 2021 for management of chronic pelvic pain. They included 4 RCTs of 216 patients. They were uncertain that adhesionolysis had any benefit. They were uncertain about laparoscopic uterosacral ligament or nerve ablation. They didn't find any studies that met their inclusion criteria for neurectomy, pelvic pain ligation, or hysterectomy. And they basically were uncertain about any surgical impact. And then for non-surgical, they found that various medications were effective, and that basically moderate quality for progestin, and that was pretty much it. And then reviews including information on hysterectomy for chronic pelvic pain really were poor quality and difficult to determine. ACOG in their practice bulletin on chronic pelvic pain recommends pelvic floor physical therapy, cognitive behavioral therapy, medications. They do talk about not using muscle relaxants or opioids. And then acupuncture and yoga may be considered, and they don't recommend surgical approaches. So the basically in summary, the systematic reviews and meta-analyses that were identified found evidence of effectiveness for pelvic PT for including pain and quality of life that had minimal clinical, but it was statistically significant. And the therapy is recommended by ACOG. Evidence was found for various medication options that also are recommended by ACOG, and those are currently available. No evidence of effectiveness was found for cognitive behavioral therapy, although this is recommended by ACOG for women with coexisting anxiety and depression. No evidence of effectiveness for acupuncture, TENS, adhesionolysis. Hysterectomy as a treatment for chronic pelvic pain is poorly studied. One cohort study reported a high rate of continued or even worsening pain, and ACOG doesn't recommend it as a treatment option. So the HERC staff recommend placing chronic pelvic pain into the code grouping for PT and OT services because of the pelvic pain, with some possible clinical effectiveness and recommendation by expert groups, but not to put it in with paired with any surgical interventions. And then the guideline note that would currently be for chronic pelvic pain. The EBGS wanted the top half of this guideline kept rather than struck out, but turned into a diagnostic guideline, because it's really a diagnostic guideline for when we would do a pelvic diagnostic MRI. So that would be the main, that we would keep the guideline but convert it to a diagnostic guideline. Lots of stuff I just blurted out at you all. Questions?
Lots of stuff that people have tried, and it's just a really tough thing.
It's a tough diagnosis.
Yeah, it is. Wonder when there'll be a good advancement, maybe better diagnosis.
That would be great.
Yeah.
Because it's
It's a tough-
debilitating for those people who have it.
Yeah.
Any questions about the gynecology? Otherwise, I can move on to the dermatology. We first had sort of our general dermatology.
Page
Page
438.
438.
Thank
Ooh,
you.
in stereo.
And basically.
Hey, Ariel, quick question.
Yes.
I was looking at page 411, pelvic congestion syndrome. Is that included?
That would be under the general gynecology, and it was recommended for evaluation and medical management only.
Okay, not for ovarian embolization or other surgical interventions, correct?
It would be an evaluation of medical management, which wouldn't have anything other than office-based procedure, office visits.
Okay. Okay, thank you.
So for the general dermatology, the recommendation is to add coverage for a couple of new diagnoses, including pseudofolliculitis barbae, which is similar to severe acne. And then hyperhidrosis, which we would pair with chemodenervation in the axilla, but not palmar. We'd remove the current guideline note that reflects palmar, and that's due to the evidence that it's not effective. There was a lot of discussion about hair loss and wigs that you'll hear about later. That's going to come to the next EBGS meeting for more discussion. And then most conditions that are currently in the moderate to severe inflammatory skin disease line would be in a new code grouping for inflammatory skin disease with the current guideline with just technical modifications. So essentially, a lot of current coverage with just the technical changes that we would need to convert it over to the BUP. We did have a few additions that are a little bit more that are chronic inflammatory skin disease guidelines. The experts wanted us to put in some specifications. If you don't meet the, moderate to severe conditions, you still get moderate, like topical antihistamines, low potency topical steroids, and other over-the-counter therapies. In other words, we're not treating them, we're just kind of clarifying that. And then for our severe atopic dermatitis and eczema, we currently list out a whole bunch of drugs, and at the request of our PNT colleagues and the experts, we're basically saying we covered drugs. And we're not specifying which type, et cetera. We are keeping the targeted immunomodulators need a couple of the criteria that are currently in there.
I see no lichen sclerosis, which is a very rare condition, but maybe it's not. It's probably covered at some point, but
I think it's already on a covered line, or is it
I don't
not?
know. I just word searched it.
We do cover it when we it's mostly topical steroids.
Yeah, okay. I was just looking at all the lichens and I'm like, oh, we don't have them.
Yeah, and then there's some wording changes that were done during the allergy review that allows some patch testing for dermatitis that was reviewed previously with the allergy recommendations. And then kind of regular old BUP kind of changes. The only friendly amendment I'd make, because I realized that this still had the date of last review being June, it will actually be August 2025. So minor little change. We can just do that administratively as we collect all of these. Just as a reminder, all the BUP topics will be coming back. We are extremely hopeful they'll all be coming back to you in November as a package. And there may be some changes here and there with small updates for your final approval. So we looked at actinic keratoses to remind you all that these are skin changes that are sun-induced. They can
Page 452.
They can lead to squamous cell cancer. They are treated in a couple of ways: topical drugs as well as cryotherapy, which is freezing, or other types of surgical kind of removals. We talked about this at our last meeting and at our meeting in May. And we talked about it in May? Oh, it was May 2006. I apologize. Never mind. So the evidence is that the topical medications work really well. And that all the different various flavors of those work okay. Photodynamic therapy, which is where you use light with photosynthesizers, also that actually doesn't work as well as cryotherapy, but is useful in certain patient populations. And expert guidelines, the dermatologists recommend using sunscreen. I think that should just be tattooed on all dermatologists. They support the 5-fluorouracil and equipamab. These are the topical medications that are used. They also found evidence to support cryotherapy and photodynamic therapy. Other payers are covering a variety of treatments. So EBGS talked about this in April. There was discussion about the cost of cryotherapy. It's individually inexpensive. As a population, it would be quite expensive. And AKs are, excuse me, very common, and these are commonly treated in the primary care office. And they noted that there's difficulty accessing dermatologists. So they had some concern that we should add some cryotherapy because that is the most common treatment in primary care. Then there was some discussion about whether these actually progress much. They ended up recommending covering cryotherapy with guidelines limiting it to use in high-risk situations after all that discussion. But they were interested in having you all think about removing the limits on cryotherapy if you felt that it would improve access to treatments, for example, in the primary care setting. When we discussed this again in June, we talked about phototherapy, and that should be a third-line treatment because of we've worked with our pharmacy colleagues. The medications that they use for that are extremely expensive, and they're really useful only for a very select group of patients. So the EBGS recommendation for you all to consider is to add actinic keratoses to the premalignant dermatologic lesion line 240. It would pair it with various cryotherapy, excision procedures, and photodynamic therapy. And you would adopt a new guideline that would say topical medications are covered for all actinic keratoses. Treatment with cryotherapy is only medically necessary if you haven't had sufficient response or a contraindication to the topical medications, and you are either immunocompromised, have a history of skin cancer, or it's located in a few sensitive areas on the face. And that photodynamic therapy is only medically necessary for patients who would otherwise qualify for cryotherapy as above, but fail to respond to or have a contraindication to cryotherapy. So essentially making that third line. Lots of stuff in there. Thoughts, input, questions?
So it sounds like we had a question about cryotherapy, adding cryotherapy. Yeah.
So
I don't have the experience, but
there was just a question about how restricted we want to get.
Mm-hmm.
It's an easy, quick therapy, but if we cover it, there would be a dramatic increase in costs.
Yeah.
So the dermatologist felt that actually the topical medications were really where you wanted to go.
Okay.
Because typically if you have one AK, you've got more sun damage, and it kind of it's a field therapy. It affects the whole sun exposed area rather than just a specific lesion. And then the last topic is cyst scars, granulomas, and keloids. So initially, the recommendation before this went out for public comment was to cover with a guideline for when these are painful or restrict the motion of a joint or have other complications. We received a public comment from a HERC member who couldn't be present today. He was very concerned about the guideline. He felt it wouldn't be implementable. He thought it was really should be left for the exceptions process. So HERC staff have created two options for you to discuss. So these are cyst scars, granulomas. These are benign. They're not going to cause major issues for you, but they can, if they're crossing a joint, restrict joint movement. They can become painful. They can be disfiguring, particularly for like keloid scars. So the current staff recommendation is the first option would be to create a new code grouping, keloid skin cysts, hypertrophic scars, and granulomas. And then you would be a guideline saying that the following diagnoses only require treatment when there's evidence of significant functional impairment, defined as having functional impairment as indicated by the Dermatology Life Quality Index DLQI greater than or equal to 11, the Children's Dermatology Quality of Life Index greater to or equal to 13. And that would be for the cysts, scars, hypertrophics, etc. And the second option would be to place all of these codes in the evaluation and medical management group, and then treatment would go through the exceptions process. We have to discuss this one. There's two options. So
Happy to.
yeah.
Have you solicited input on the implementation concerns from other medical directors?
So this was Matt Kaiser. He was concerned that the quality of life indexes are not actually they're not created to look at these particular types of skin conditions, although our dermatology experts thought that they would be appropriate, although they haven't been previously sort of validated as a measure for those. They're validated for other many types of skin conditions.
So wait, I'm gonna drive any hands up. So wait, because I'm just gonna make sure I understand. So the concern for implementation was that this index that is written into the guideline note has not actually been validated in these conditions. The dermatologists, though, that were the subject matter experts, do feel that it would be kind of an appropriate extension and could be generalized. Is that the crux of the concern?
Yeah, that's a good summary of it.
Okay.
I think Max's other concern was that these are all very common conditions and typically don't need treatment. And this would, I think he thought widen coverage to too much. Oops, I can pull up his actual comment.
I would add just for the health disparities aspect. There are people with more melanin may have more of like the keloid and the scarring kind of thing, and so I mean it might if we cover it, the health effect might impact more people who would be in the more typical kind of marginalized populations. So I don't know.
This is Chris. Are the high risk, sorry, I'm a little faded. Are the high risk conditions where the cryotherapy are not recommended called out anywhere?
I'm sorry, were you talking about the actinic keratoses or the scars and cystic granulomas?
I guess I was going back. Yeah, I guess I went back a topic.
Okay, do you want to talk about the AKs? Because we did define them. It's people who are immunocompromised, they've had prior skin cancer or sure, it's in the guideline. There's a third.
Okay, thank you. That's what I needed. No.
Prior history, and then it's located
In areas that you can't use the topicals.
Okay, just
Got it. Thanks.
I'm sorry, not in the database.
Oh,
I have a question. What specifically is, on what basis would one object to using the Dermatology Life Quality Index?
So Larry, I'm gonna have you hold that because Chris's question was about a previous topic. So I think maybe we should backtrack and not.
Okay, no problem.
I'm just gonna try to keep things clear.
Yeah.
439.
Yeah, that answered my question.
Oh, that answered your question. Okay.
Yeah, thank you.
Perfect. Okay. Go ahead, Larry. So why don't you jump us forward, and since it sounds like Chris's question's been answered.
Okay. Is there any objection to using, I'm not clear on the objection to using the Dermatology Life Quality Index.
I am not an expert on these indexes. I asked our dermatology experts, and they felt that it was sort of a general skin condition, functional impairment, index, but it is only validated, Dr. Grayling and Dr. Doshi answered my question. They did agree it is only validated for inflammatory skin conditions, but they felt that keloids and hypertrophic scars may actually be a inflammatory skin condition if you want to get really, really technical on etiology.
So why would the dermatology life quality index not be used?
I guess my question would be is why would it be used? Is there any published data that has this index used for scars?
I don't believe so. I can't tell you that with 100% certainty, but I don't believe so.
And that's maybe because it's not validated. So that's I'm going to be the naysayer to say that if there's nothing published, I would not jump to the conclusion that there's a correlation.
Okay, I believe the dermatology life quality index is validated, but whether it is validated for specifically these conditions, that I do not know.
And I think that's what the dermatologist said, right? It was validated for other conditions.
Yeah.
And but that it made sense to them clinically that it would apply the same because it's a skin disfigurement. Do I have that right? I'm reading between the lines. Okay.
So if you look on page 463 of the packet, that's where the summary of the expert input is located from the two OHSU dermatologists. And if you go lower in the packet is a little bit more detail of what Max's concern is.
Well,
yeah, when I pulled up his public comment, he said, I would not support the addition of a guideline note for cyst hypertrophic scars and granulomas. Similar to our lipoma discussion, presentation of these diagnoses are too varied to adequately craft a guideline note. I would support leaving intervention on these lesions to the exceptions process.
I have a question about that. Because different types of skin respond differently in these different conditions. And OHSU dermatology, my question makes me ask the question, do they see people who have a lot of different types of skin? And so are there other dermatologists in maybe other parts of the country who have more experience with more skin types and may see this a little bit differently?
Thank you for the comment, Larry. What other comments do the group have? Where's everybody at with this?
This is Chris. I guess I keep thinking about what Larry with the dermatology life quality index.
You're breaking up.
What's that?
You're breaking up.
You're breaking up, Chris.
Oh, bummer. Let me turn off my video and see if that helps. Is that any better?
Yeah.
Yeah. Okay. So it just the conversation reminds me of our vitiligo discussion a while ago, and part of the vitiligo really addresses it had some really good markers for addressing the psychosocial and mental health aspects of that issue with some criteria more about how much of your what area of your skin was covered and where the vitiligo was happening, but it was comprehensive, so it wasn't just physical, it was also acknowledging the mental health component of it. And I'm just wondering if that's where if the dermatology life quality index is a way to bring that in to try to make it uh, kind of have a more a spectrum or a line of discretion between where these cysts become functional impairments, and if functional is purely physical or is it also mental?
I think your point is really good because I think the index actually is not so much disease specific, but more a measure of how a skin condition affects their life. Yeah.
So,
Mark,
just
your
to
hands up.
remind you all of our April discussion, this was, you talked about, our EBGS members talked about this at their April meeting. At that point, the staff recommendation was just allowing treatment for those conditions if they cause pain or functional issues. Members thought that that was too vague and they wanted criteria. And they asked to see if there was something objective, and that's where we reached out to the dermatologist and got the scale. They did note that there's EPSDT and the appeals process to allow coverage in rare conditions, but that if we could find some type of validated scale or instrument, that would be preferable. So I guess you have to question whether this is a validated scale for this or not, or whether you want to cover
Yeah.
some.
It sounds like that from the expert guideline statement. They noted that the index is validated for any inflammatory skin condition, including keloids and hypertrophic scars.
Well, it's been validated in inflammatory skin conditions, which are things like psoriasis, eczema, those. And then scars and keloids are a type of, so I would kind of parse that a little differently. I don't think it's been studied in scars and keloids, but they thought that it would be similar because of the underlying etiology. So I would parse it slightly differently. And Mark, I see your hand up.
Has there been feedback that coverage keloids or scars have not been covered? I mention this because the exception process does work. We do see a fair number of cosmetic requests, purely cosmetic, for keloids and scars that are not currently covered. If it interferes with movement of the hands, wrists, knees, and it's a functional limitation, those are currently covered. And that's just my yeah, agreeing with the exception process, that the current process does work.
We did hear from one surgeon out in Eastern Oregon that she was getting denials for some cyst requests. That's the only feedback I have gotten.
Yeah.
So
this is Chris. So Mark, do you think that if it's going through the exceptions process, then, and it's for the same situation, would this criteria or would this scale, do you think that would make it a little more equitable as a standard, or do you think that you would see less people having to go through the appeal process, or is the concern that it might be too many people coming through? Or
I guess that's what I don't have experience with this scale for a cosmetic. If I take a cosmetic keloid or scar, would it be qualified under this if this scale was positive? And that's what I don't know. So my gestalt would be that it would increase utilization for non-functional keloids or scars.
What kind of numbers are we talking about?
scars and keloids and cysts are very common. How many people would want treatment? I don't know.
Okay.
Oh, if we include inflammatory cysts, thousands.
Well, how many have you, as a medical director, Mark, do you have any idea of a number of how many of these requests or appeals come through on a monthly basis or on an annual basis?
I can't quote numbers, but I can quote that it's lots. This is a substantial prevalence in the community.
I think knowing some numbers would be helpful.
Would this be in claims data that we have access to?
No,
Or no,
the
or
difficulty
is-
is if the PA requests are denied, we at OHA don't have access to that information. The CCOs might individually, but they also might have different policies or practices that might influence how the criteria are applied.
Lisa. So, I might recommend that we come back because, but not that it's anything formal. But I recall an email that you sent out when we start Googling and we start looking at things to come up with answers to questions. That's when maybe we want to send it back to get more of an official answer. I found myself Googling this and I found that from my Google, it seems to be absolutely the standard. I mean, so I would want that answer, I think, from HERC. Is this the standard validated test for determining the degree of severity and impact on quality of life for our subjects? Which it kind of looks like it is. And then I think we may need a better understanding of what a score of greater than or equal to 11 on the adult and greater than or equal to 13 on the children. I think that would help us answer what that threshold is. And one thing that, I mean, I feel slanted to have this coverage just because of how these conditions disparately affect populations. And so.
I agree with I agree with that, and I'd also would wonder if Marcus and his group could get some actual numbers.
So why don't we do something similar? We're reaching after 4 o'clock. I know we've been going for a long time with no break. I'm thinking in my head that probably if we're gonna go 3 hours, mental note to myself that we need to do a break. Because I find my mind wandering. Why don't we do a quick straw poll to see where people are at? Would they, are they leaning towards, I will say like option one, which is to consider adding coverage, or there is an interest in considering to add coverage. And then we can ask staff to look a little bit more into what the dermatology quality of life index is, and bring that back. Or since I've heard enough people, I think also express kind of some reservations about generalizability and how the number of people might be impacted. It does seem like there's some people that are all ready to move towards option two. So I guess I'm looking for kind of a straw poll. Nothing is binding, but are people in the option one category with potentially looking for some more information, or are people in the option two category? So I'm looking at pages 463, 464 of the packet.
Are you ready?
And Daphne, will you call roll?
Absolutely. Mark, 1 or 2.
You're muted.
Skip me, come back to me at the end, please.
Absolutely. Stacy,
Option one.
Ben,
Option two.
Lisa,
Option one.
She's number one.
Larry,
Option one, and I'd also like some numbers.
Chris,
option one.
Katie,
Option one.
Leslie,
Option one.
Mark.
I think I'm one of those that my mind was wandering. Refresh me on option 1 and 2, please.
Option one was what came out of the EBGS committee. Sorry, even my mind. And that would be to expand coverage, and then it utilizes the validated questionnaire. It does seem like there is some interest in getting additional clarity on this scale before heading down that route, but that would be option one. Option two is you're ready to make a decision that you do not want to add coverage, for either concerns related to validity of the instrument with these disease states, or the broad nature of these types of conditions.
Option 2.
Yeah, I want to be clear for option one, when I say the numbers, not just the validity of the scale, but also how many people are actually requesting this type of this treatment.
Well, one of the things with that, Larry, is we don't know about chair side denials. And I'm sure Jason
Yeah.
has more to say.
Yeah. That's a good
So,
point.
okay, and the other, it sounds like we're kind of on the fence. I don't think, I'm not hearing a consensus. You want to make a decision. So it may be good for HERC staff to work on this further.
Yeah.
If we have something ready for the September EBGS meeting, we can bring it back to them and then bring it back to you in October, or we can bring it back to you directly in October.
That's what I'm saying.
And I may be able, I may reach out and see if one of our dermatology colleagues can come perhaps.
Yeah.
And
That'd be great.
Yeah. Okay.
That would help give context if it's
Yeah.
really standard for their whole practice versus by disease specific issues.
How many people would it, you know, addiction?
So the pieces that I'm hearing just from as I've kind of listened to the conversation is kind of information on how, I guess, the populations where this scale has been validated, and then if it has not been validated specifically within these disease states, the likelihood of generalizability. And then the second thing, Larry, with kind of, I'll just caveat that it may not be possible because of the bedside denials, but if there's any opportunity for what would be the scope of requests that would come through would also be helpful from a group. Are there any other, again, I've seen Ariel make lots of notes next to me. Is there anything else that folks want to make sure gets pinned for this conversation?
I think Lisa's was very valid. Like, what are the populations that are there populations that are disproportionately affected? Because again, if it's the appeals process, I can tell you that many people won't even know that that's an option.
Okay. Thank you for highlighting again, Chris.
Trouble. Yeah.
Okay.
Yeah,
So I'm thinking that this is a table. Go ahead, Daphne.
Oh, I'm sorry. From my outreach work, especially in rural Oregon, there were a lot of people who didn't know they could appeal or know about the ombuds team or any of that. So I had a lot of fun educating people in rural Oregon. That's all.
No, thank you. And thank you for all of the outreach work that you do on a regular basis as well.
Oh, you're welcome. Thank you so much.
so, so if we table this, then we would move to approve the EBGS report with this, the granuloma cyst keloids tabled.
Yeah.
So that is the end of the EBGS report. So is there a motion to accept the gynecology and the dermatologies A and B, or the first two parts of the dermatology?
I make a motion to accept.
Okay. Do I have a second?
I'll second.
I have a second from Lisa. Any discussion? Okay, Daphne, why don't you call roll or
Thank
call
you.
the vote?
You bet.
Why?
I'll do something with this list. Mark?
And that excludes the one we were just talking about, the cyst, correct?
Yes.
Yeah,
granulomas and keloids.
That's what I thought. I agree. Approve.
Stacy?
Approve.
Ben?
Approve.
Lisa?
Approve.
Larry?
Approve.
Chris?
Approve.
Katie?
Approve.
Leslie?
Yes.
And finally, Adrian.
Approve.
That passes.
All right. Our next meeting will be October 9th, 1:30. Hybrid meeting again. Does anybody know right now that they can't make it?
Wait, are we not meeting in September?
EBGS is
The
meeting?
EBGS will meet on September 11th for those of you on that subcommittee.
That's right. Okay.
I think I might not.
So if you can't make it, please let us know so we can make
So
sure.
date again, October.
October 9th.
Most likely not.
We'll do a quorum check for sure. So if you don't know right now, it's totally fine.
Okay.
Anything else? Any final comments or questions? Okay.
Anyone else out in the viewer world have any public comment that you are, nothing? You didn't sign up?
We had no one else sign up. Yeah.
Okay. Well, with that, I will adjourn the meeting. Thank you, everyone. Lisa's like, I have a tendency of banging the meeting hard. I will
Great.
half lightly, and we are adjourned, and I will see many of you in October. So have
Thank
a
you all.
great end of the summer.
Thanks, everyone.
Thank you. Bye-bye.
Bye.
So nice seeing